Hi, my name is Asma, and I'm going to talk about how we are using artificial intelligence to help with the rehabilitation assessment process using smartwatches. This is a part of the European project 3D kinematics for remote patient monitoring. Let's take an overview of the actual rehabilitation state. Any middle-aged woman or man is highly exposed to the risk of getting hit by stroke. If you survive the stroke, you will undergo a rehabilitation process in order to recover a part or most of your functional abilities, depending on your situation. The present issue is that if the rehabilitation process is not optimal and accurate enough, the patient may lose a part of his functional abilities forever. That's why it is important to have a continuous evaluation of the patient's physical condition. Actually, the way you are assessing stroke patients now, in particular the upper part of the body, dates back to 40 years ago, and the assessment is at most performed once a week, so it's not continuous. The idea is to use artificial intelligence to help evaluate those functional abilities using non-invasive sensing in a continuous manner, so we can provide better rehabilitation. To do so, we designed an application scenario that mimics real rehabilitation conditions. There exist two scenarios, L1 and L2. L1 is a combination of 4K movements. Those 4K movements are inspired by the Fugl-Meyer scale, which is actually used widely to assess the performance of the patient. And L2 is the second scenario, which is more close to real conditions, is a combination of the 4 previous movements and a set of random movements. First, the signals are captured by a sensor, which is in our case an Apple Watch in each hand. The signals are being processed entirely, or only a part of the signal is, or only a part of the action is being processed through a baseline classifier, which is an SVM or a CNN architecture. The outcome of the baseline classifier is to determine the K movement. The activity recognition chain is a part of a larger assessment pipeline that ends with the kinematic model. The kinematic model analyzes the movements and determines the patient's progress. Since there exists no public similar dataset for stroke patients, we had to create our own dataset. We recorded 25 healthy subjects and 4 patients. We succeeded to have a patient from each different age category. Due to the size of the dataset, it makes sense that SVMs performed better in our case. We reached an accuracy of 84% with SVMs for L1 and 61% for L2. The accuracy decreases with CNNs to 65% for L1 and 59% for L2, which makes sense because CNN is a very data-hungry learning method. In the coming time, we will integrate the spotting part within the bigger assessment pipeline. In addition, we will work on weekly supervised scenarios and data augmentation to face the lack of the data that we have. And we will try to enlarge the work scope to spot K movements in the wild. Thanks for your attention. For any further details, meet us at the IHA poster session. Thank you.